This 25-year-old IT professional who was charting a successful career is on the verge of giving up her dream of starting her own tech company. Her ocular discomfort has been terrible for last 2 years and no one is able to offer her a solution. Changing lubricant does not help and her test keeps showing inconsistent results. She asked us, "Should I change my career? Is this all in my head? Can't you give me new eyes, doc? I can't go on like this forever."
Looks like it's going to be a good day. What a great day to treat eyes. Just a couple of patients to see, and then I'm free. Wait, why is my OPD full of dry eye patients? When will this OPD finish? Here's another dry eye patient complaining. How many times can I hear the same complaints? Nothing seems to help them. Someone help me.
And yet another LASIK done successfully. Alright, she's 6'6" post-op. I bet she's happy. Why is she giving that expression to me? She doesn't look happy.
What's the point of getting LASIK done if I can't see anything? I can't even open my eyes.
Oh, at least I don't have to sit and listen to complaints about dry eye. After I do this mature cataract, this patient will be really thankful to me. You can see all right, ma'am. You couldn't see anything earlier, but the surgery has been successful.
The surgery may have gone off fine, but what's the point? My eyes are constantly burning.
I don't know why some of our LASIK, cataract and dry eye patients are so unhappy. Is there something which we are missing? Are the normal metrics enough?
Ouch!
A sudden change in temperature can trigger tooth sensitivity. Maybe something similar is happening on the ocular surface. I think it's time to dig a little bit deeper into this.
Concept of ocular surface thermography was introduced in 1968 and allowed evaluation of normal and pathological conditions. Prior thermography studies have shown that the cornea is warmest at the limbus and coolest at the center. In dry eyes, it was noted the temperature differential between the limbus and the corneal center was higher in dry eye. This evaporation rate may trigger receptors like TRPV1 and TRPA1, which are temperature and pain receptors in the cornea, thus leading to ocular surface discomfort. To investigate this hypothesis, we use novel artificial intelligence-based non-invasive imaging modality. We analyze patients with ocular surface symptoms, normal patients as well as patients who have undergone prior refractive or cataract surgery. We subject all our participants to OSDI questionnaires, Schirmer's, TBUT, meibography and tear film analysis using oculus keratograph and LipiView. We also used a novel thermography device. Our thermography device uses long wave infrared camera. The patient is asked to blink and the device is started. In the normal blink mode, a video is captured over 30 seconds asking the patient to blink normally. In the restricted mode, the patient is asked to not to blink for as long as possible. Changes in the ocular surface evaporation rates are captured and then processed using a novel AI-based algorithm. Here are some examples to elucidate our findings. Darker colors in our temperature maps indicate warmer areas and the lighter colors indicate cooler areas. First case is that of a healthy subject. The OSDI, Schirmer's, TBUT, lipid layer thickness are all normal. The thermography map taken in restricted mode show virtually no change up to 10 seconds. Our novel score calculated by comparing OSDI and change in the temperature profile is also low. This patient has no symptoms. In the second case, the patient has evaporative dry eye with high OSDI score along with low TBUT and lipid layer thickness. The thermography maps taken in restricted mode show an increase in the lighter colors indicating evaporation and possible triggering of the thermal receptors causing pain. The third case shows the patient with symptoms where all the conventional metrics are normal. The thermal profile, however, shows the change over 10 seconds. These are the cases where possibly patients would benefit by having a look at the change in the ocular surface temperature, where the conventional metrics doesn't allow us to make a correct diagnosis as to the cause of ocular surface pain. We found that in our series of over 200 eyes, OSDI correlates directly with the change in the temperature profile on the ocular surface. With this device, we were able to discriminate patients with mild symptoms where the novel score was less than 1.1 and the moderate and severe symptoms where it was greater than 1.1. The sensitivity and specificity was comparable with the other diagnostic devices. This case shows a patient post-PRK where we placed a cold bandage contact lens in the left eye and a normal bandage contact lens in the right eye. The eye with cold BCL shows less change in the temperature profile at the end of the restricted blink, and the patient symptomatically appreciate that there was a less pain in the eye with the cold BCL. Therapeutic implications of this include using cold BCL post-refractive surgery and the eye drops kept in the fridge door so as to lower ocular surface temperature and consequently less pain. We propose thermography as a novel, non-invasive way of imaging the ocular surface in patients with ocular pain. When on the ocular surface there is pain without stain, it is for the ophthalmologist's existence the biggest bane. How to solve this mystery that seems oh so plain? Everything about it seems to confound the brain. When the Schirmer's TBUT and mebography doesn't correlate, it is the thermography that may help us to relate. Remember, it is the surface temperature that fluctuates that makes the patient uncomfortable and irate. Controlling the ocular temperature may be the key to keep the cataract and refractive patients happy. To conclude, I would just like to say, cold BCLs, chill BSS and drops may pave the way for you and your patient to have a great day.